Yeah, today we shall be discussing on orbital inflammation. I will be taking you all through the anatomy and the location of lesions. Okay. I have no financial disclosures. Orbit is always known as the Pandora's box. So whether the orbit tells us a story or gives us a nightmare depends on us on how we look at it. Now coming to the anatomy, we have the orbit which houses the globe and the periorbita. We have the superior orbital fissure in the apical region, annulus of Zinc, the LFT nerves, the vessels, and based on involvement of these structures, we have the superior orbital fissure syndrome and the orbital apex syndrome. The differential difference between two is the involvement of the optic nerve or not. Now, what are the questions that should always be on our mind when we are looking at a hot orbit? Where, when, why, and how? What are the signs and symptoms? Was there any predisposing injury or surgery? When is the onset? And where is the location of the symptom and the radiological localization? We will always find the signs of inflammation, whether it's infection or inflammation. Rootman has classified hot orbit in form of systemic inflammatory disease, which may be thyroid eye disease, Wegener's granulomatosis, neoplasm, which may be rhabdomyolymphoma, or any congenital lesions which have been secondarily infected or inflamed. And NSOID, the reason why I have put NSOID in the last is because it is a diagnosis of exclusion. Now, this 6 P's must always weigh on our minds: pain, proptosis, progression, pulsation, palpation, and periorbital changes. Now, keeping these things in mind, let us go through a few cases. This was a case. It was sent to us by Dr. Bhaduri sir. He was a 12-year-old male having recurrent swelling in the left eye since the last over a few weeks. On imaging, we find an abscess. We had sent the sample after incision and drainage for culture sensitivity. And after a course of IV antibiotics and FES being done, he had recovered wonderfully. This man, he's 80-year-old. He had undergone cataract surgery a few days ago, and he presented to us with pain, proptosis, restriction of eye movement. So this was a case of panophthalmitis. This was a unique case. This patient had a history of gradual progressive painful swelling in the left lower lid since about a few 3-4 months. I was thinking on the lines of lymphoma. I had biopsied it twice because I thought it was lymphoma with a diffuse mass and around the orbit, which is in the orbit surrounding the globe, but it came out to be granuloma pyogenicum. This is of the COVID era. This lady had rhino-orbitomycormycosis and was treated mainly in the ENT department, and FES was done in there. Now coming to the inflammatory lesions. We all know this is a typical case of thyroid with mostly in the active form because of the congested eyes, the proptosis, and the fullness of the periorbital regions. They may also come with restriction of eye movement. It may be in the quiet form also. We know the antibody and the molecular mimicry which goes into the pathway of thyroid eye disease. Whenever we think of thyroid, we should always keep the Rundle's curve in mind. We should know whether it is in the active phase or the inactive phase. In terms of this, we have the activity score and the severity score. Recently, yesterday, I heard about a low-grade clinical activity score, which is less than 3. Now, this patient came to us about 2 years ago when he had a small swelling in the left lower lid. We can see a slight pinkish salmon pink appearance in the medial caruncular, in the medial region, medial palpebral region. We had advised for an biopsy, but the patient was lost to follow-up and then came again in 2024 end for a biopsy. This was a case of lymphoma. We can see the mass surrounding the globe, but not pushing it. Similar case, bilateral involvement of the orbital fat. Here the salmon pink appearance can clearly be seen in this man. Okay, these are the congenital lesions or dermoids which may secondarily be infected, or there may be a ruptured dermoid leading to a inflamed orbit. This girl, she was about 16 years old. She had an osteosarcoma of the uh, right tibial joint, right tibia, and she came to us with a stridadiate lesion, which is a neoplasm. I will not go to the diagnosis in detail, but I will just uh, put certain things so that we know what to look for and where to look for it. Okay, this lady, what we assumed initially was a sebaceous gland carcinoma. Basically, it was a lacrimal gland carcinoma, which had presented with rapidly progressive swelling in the right orbit. I was not very sure about the diagnosis of this boy. This child, he had come to us with bilateral proptosis with a hemoglobin 5, HPLC showed HB trait. He was diagnosed as Erdheim-Chester disease somewhere else. His serum ferritin levels were raised, but we know that in Erdheim-Chester disease also, the child can come to us. It is a child can come to us with bilateral proptosis. It is a form of non-Langerhans cells carcinoma. Now, coming to history and examination, for trauma, we have to take a detailed history. There may be some incidents of trauma which may slip the mind of the patient. For infection, we should go for a blood culture and a CBC. But whenever we are thinking of an infection, we should always start with the empirical therapy, not waiting for the culture or the imaging. We can, for thyroid, we should do the thyroid profile. For lymphoproliferative diseases, we have the CBC, the imaging. For sarcoidosis, the ACE and the lysozyme assays. And for Wegener's, the ANCA and the PNS images, whether there is any destruction of the PNS. When all are ruled out, then comes the idiopathic inflammation. There has been many names, non-specific orbital inflammation or IOID, but it is benign, non-infections, and often recurrent. In our population, thyroid comes first, then comes lymphoma, and then comes the painful orbitopathy or NSOID. The few common features are based on the location, anterior diffuse apical, myositis or dacryoadenitis. The uncommon ones are periscleritis, perineuritis, or focal mass. Always a diagnosis of exclusion. Now, as per the location, most common is the orbital fat, then the lacrimal gland, the insertion of the muscles, and the optic nerve, and finally the sclera. A study was conducted by Swami et al., which showed that the lacrimal gland and the orbital fat are the most common parts to be involved. Coming to the differentials, it may be of NSOID, maybe myositis due to thyroid ophthalmopathy or orbital lymphoma or CCF. What must be borne in mind that thyroid ophthalmopathy is always bilateral, mostly bilateral. It spares the tendon. While in CCF, we can see the SOV, we can see the flow voids, we can go for an angio, and we can see the retrograde flow of the blood. Now, when we have a case of dacryoadenitis of NSOI origin, then we must always rule out orbital lymphoma, where we can see a palpable mass and we can see a trailing sign on the image. And there is diffusion restriction in orbital lymphoma because the mass is densely packed, and so there is diffusion restriction. The apical lesions include orbital lymphoma or metastasis or Tolosa-Hunt syndrome, which shows a waxing and waning progression. Diffuse inflammation in the form of granulomatosis or anterior lesions in the form of cellulitis. Now, a consensus diagnostic criteria for orbital inflammation has shown that painful red eye, orbital pain, and enlarged muscle tendon is present in almost 70% of the patients. The clinical presentation may be in the form of pain, proptosis, diplopia, with or without decrease of vision. We should assess the lid, the orbit, the extraocular muscle, and the optic nerve function. Systemic correlation must be dealt with by doing the blood profile and blood profile mainly. Yeah. This girl, she had a swelling in the upper eyelid. We had started with IV antibiotics and oral steroids, which subsided with time. Often in case of myositis, we can see the enlargement or the inflammation at the site of the muscle insertion, and the medial rectus is most commonly involved. There is often recurrences seen. There is no sparing of the tendons in case of NSOI. In dacryoadenitis, there is an S-shaped upper lid deformity. It may be associated with Sjogren or may run a chronic course over a period of time. Now, diffuse anterior variety may have a CT scan showing enhancement of the uveoscleral region, just as we see here. Or we can see the T sign. We can see the T sign as the last slide. In case of apical variety, there may be Tolosa-Hunt syndrome, the orbital apex syndrome, or cavernous sinus disease. The tramline sign is seen when there is involvement of the optic nerve. These are my references. Thank you.
Thank you, Sripurna. That was an excellent presentation. So many varieties.